monitoring for the next generation is starting now. 20% of the world's deaths and disabilities are due to undernutrition. So better nutrition empowers people and communities through improved intellectual capacity, income generation and access to assets, poverty reduction, and rapid development. So it's very vital. When should we intervene? It is the window of opportunity is the 1,000 days, first 1,000 days. Beyond 2 years, starting is largely irreversible. So, whom to intervene? This is the pregnant woman, the breastfeeding woman, children under 2 years, children childhood period, and the adolescent girls. So now what is Management Information System, MIS? It has become a very important thing for us, for our improvement, and also include how can we improve it. MIS provides information that organization needs to manage themselves efficiently and effectively. Used for managing technology, people, that is individuals, groups and organizations, all are recorded over here, and the data, information, and this is required for the decision making and the policy making is being brought from this MIS. So purpose and benefits to collect is that to collect and store and research, communicate and use the data for the purpose of efficient management of clinics, hospital and health facilities. Information is required for research and development activities. It is a molecular operational research and economic studies which contribute to policy development and service planning. As before, the planning can be started. And what is needed for the next work for the country, it can be decided from here. Nutritional status of Bangladesh impact on if the nutrition is not proper, we are getting on with the harm of infant mortality, maternal mortality. We have done a very good work on maternal mortality and infant mortality, but we have still to go far to reach the MDG goal, and not only the MDG goal, our target is that to save each and every child and mother. So, health and allied indicators related to maternal and child health. Lastly, on overall socio-economic development to increase production and improve living is the target for the nutritional status of the country. Better information, better decisions and better health to deliver timely, reliable information to the planners, managers and professionals of the health sector for evidence-based decision making. Currently, we are having 3 different MIS recordings. One is the health, and the other is with the family planning, and the other system is with the nutrition. This has to be coordinated and integrated. Present government has taken significant initiatives for improvement of MIS at all levels. So, with better information, better decision, and better health, we, through the MIS, we want to do more advancement in this sphere of health. What is the training prevalence of hunger rate in under 5 children in Bangladesh? Can we reach the target of MDG goal? We have to move faster because we are lagging behind. The intervention with sufficient evidence to implement in all countries. The intervention has been very well told by my previous speaker. The maternal and the backward outcomes for the things we have to check the nutritional as well as the micronutrient deficiencies to be covered. For the newborn babies, breastfeeding is very vital. And the infant and children also need special care, special supplementation, as that was in the previous session told, the vitamin A, zinc and micronutrients all have to be very clearly, it all have been proved, and we have to take care of them properly. Advocacy on HIV and AIDS violence against women project, we have worked with adolescents, we have tried to work for the adolescent health, essential newborn care is going on now. So we have, we have to take care, who are our target groups and how to implement target groups. And also they are healthy, but they have some deficiencies which has to be covered.
Thank you, madam. I like your work that through OCS we have done many things, but I have to go a long way before I speak. I think it was written on the desk of Indira Gandhi when she was Prime Minister of India. I forgot the name of that poet. Now the speaker is Dr. as way forward to improve nutrition information system by National Nutrition Services. Dr. S. Mustafizur Rahman.
So, good afternoon, Honorable Chair, and respectable speakers, as well as the audience of this global conference on community health. Thanks, organizers. So, health covers everything. Health covers nutrition, health covers population, health covers itself. So, if 10-20 years back, somebody asked malnutrition, people, even the doctors of Bangladesh, understood undernutrition, not the total malnutrition. Now, Bangladesh is suffering from double burden of malnutrition. We have undernutrition, both macro and macro, nutrition related as well as the overnutrition and consequence. Today, I am going to tell about the nutrition information system, and it is in the primary at this moment. So, Bangladesh has achieved a lot since independence. Just after 1 year, it was included in the Constitution, Article 18.1. But that is not enough. If we compare with the countries of the Asia as well as even Africa, we are not in a good position. So we have to achieve more. Due to multi-sectorality of this issue, we could not achieve more because it was everybody's business, and finally it was found we are thinking multi-sectorally, but we are acting sectorally. We have less linkage among ourselves. And before going to my presentation, I was listening to the presentation of my madam. It was about 1,000 days. 1,000 days means 270 days in the pregnancy and 365 times to 730 days after the delivery, after 18 years. But in my country and other developing countries, every 100 pregnancies you will find 33 pregnancies are loss in pregnancy. In every 100 delivery you will find 33 to 36 are low birth weight. So I am confused about 1,000 days. I need 2,000 days. 1,000 days we will have losses. Otherwise, we will not achieve 100%. We will achieve only 67%. Let's start with the business because time is 10 minutes. And next slide. This is the 30 minutes. Actually, I will present mainly means of the health and especially activities done by the DG Health, DG Family Planning, Director General of the Health and Family Planning, and the system of the Nutrition Information System of the Urban Primary Healthcare Sector Development Project. So what are available at this moment? actually we have the food security and nutrition surveillance project, that is a surveillance going on. Nutrition is already part of that. BDHA, MMS, anemia, child and mother nutrition survey Bangladesh, nutrition survey, monitoring and evaluation study of different nutrition problems. So, targets of the management information system, MIS, in community, actually routine activities, some e-health activities, routine activity, collection of the population information, health services statistics, workforce statistics, logistics statistics, other e-health. Nowadays, we are getting some mobile messages, medicine, SMS about many aspects of pregnancy, nutrition, and others. As well as we have the internet video and bulk SMS during the national insurance, national citizen, GIS system, digital training facilities, other ICT and mobile phone, desk, tool, etc. So ultimately, as we are managing the program centrally, we don't have local government concept that much in our health system. Finally, everything will come to the Dhaka, then divisional, then district, then sub-district, then the government level. So, tertiary, the district level and the primary level, we will be seeing both the channels. We will get some other information from the maternal and child welfare center. The scope of integration of the information in MIS. Yes, guideline of disease family planning and local government and rural development. Actually, local government rural development that is working with that the project that is UPHC, SDC, Urban Planning Healthcare Sector Development Program. Define the indicators of health, ministry and urban ministry. So probably we know about the fund scaling of nutrition, so that is a comprehensive package of nutrition. It covers all the disciplines. And finally, so board will help to maintain information from different ministries. Lack of timely collection of the program, lack of training and plan on ICT, and lack of use of information. We have a lot of information, but we are lazy to use those ones. So steps of the integration of the nutrition information system, step 1, 2, 3, 4, 5, actually analysis, the situation, access to expressors, and pick the care, identify the scopes, and utilize the process of existing MIS. So we should integrate all these things. So analysis should be there.
Thank you very much. Curate spoke to integrate nutrition information system in Director General Planning Family.
My beloved teacher, Professor Shamli, is sharing the session. And the distinguished guests, ladies and gentlemen. I'm going to talk about one of the projects nutrition. Its name is Alive and Thrive. We are working in the community component, and that is being done by Brad. It is funded by the Bill and Melinda Gates Foundation, and in other 3 countries like Bangladesh, Ethiopia, and Vietnam, they are all doing and working on the nutrition to improve the malnutrition situation among the children less than 2 years. Before going to this slide, let me talk about Brad. Brad, who was born just after the liberation, and he has got a long journey in the field of nutrition. If you look at the slide, you see, in 1993, in Mukarasa project, Brad had this nutrition project to implement with the supplementary feeding program, and the lesson which has been learned is being incorporated in BIMP project, that is Bangladesh Integrated Nutrition Project in the year 1995. Based on that experience, government and Brad and other NGOs have gone for the project of NNP, which is known as National Nutrition Project. Meanwhile, in 2009, Alive and Thrive, which has got a tremendous opportunity to work with the children less than 2 years of life to improve their malnutrition through counseling, coaching, and demonstration. We know that directly or indirectly, 1/3 of the estimated children, about 9.5 million deaths that occurred in 2006. That evidence shows in the Lancet 2008. At the same time, if you look at the slide, you see, we believe that only the highest or the lowest group of people are being suffering from malnutrition. Actually, not only the highest, not only the lowest, it has been prevalent in all the age groups, like the wealth index shows from highest to lowest going down. So based on that experience, even then, that due to the malnutrition, what the underlying cause is one of the major causes is the infection. Because if you do not wash your hands before preparing the food, even the feeding the children, definitely the child will be infected. As my professor is sitting here, the villi will be flattened, there will be less absorption of the food, and that will be the causes of malnutrition. So, with those findings, we have found that in our country, still 41% of children are suffering from stunting, 16% are wasting, and 36% of children are underweight. And most of the things which are happening is happening below 2 years. So not promoting the other products that could be and juice or other things. We're totally giving the mothers and teaching the mothers to provide the homemade food which will be cooked in our house. By this time, we have found that the social mobilization is one of the important areas to alert the people, because we know if we can't create an appropriate environment in the community, it is very difficult to go through those messages in the community advice to improve the situation of the nutritional status among the children. We have got a tremendous MIS system. We believe that everything should be in register. While we are giving the counseling, to whom we are providing the counseling, what the children have covered, everything is being incorporated and listed in the register. These two women, one is our community health volunteer and another is the IOSA promoter. They are visiting each and every household. Our Shakti got the community volunteers covering 250 to 300 households, and the IOSA promoter, she is visiting 2,500 households, and they are registering and listing the children as well as what are the services they are being providing. They are also incorporated in this register book. So our MIS group developed as a field test, and after that we audience the people to have the good MIS knowledge, and we are collecting data, and this data is being analyzed fast in the field. We are providing the feedback to our Upajala managers and other stakeholders, and they are incorporating those information and improving their situation in the community, as well as they are sending those data to our head office. We are compiling those data, sharing with our field findings with our officials, with other NGOs, even then with government people, whenever we get the chance to disseminate our activities. With this MIS process, we have found that these things are improving. If you look at this slide, we found that we started at the baseline survey 2010, the early initiation of breastfeeding was 65%. Now in the working area, we get it 89%. Exclusive breastfeeding also increased. Initiation of community feeding just after the ending of the exclusive breastfeeding, that is beginning of the 7 months, they have initiated the community feeding, and it is 93%. We are encouraging mothers to provide at least one single piece of meal should be containing the animal food because of preventing stunting, and that has been increasing tremendously. At the same time, as we mentioned, that hand washing is an important factor to reduce the infections among the children. To improve the nutritional status, we are giving them the hand washing station and giving them the counseling to wash their hands before preparing the food and before feeding the child. With those findings, we have seen that it could be done in any community, in any country. And the MIS system, which we are getting, it could be incorporated in our DGHT as well as in other sectors, in other stakeholders, to improve the malnutrition situation in the community. Thank you very much.
Cecilia and David, they will talk together, I think. So they will talk on part of my subject, critical surgical care and coronary critical care. Nursing, main medical center.
My practice has primarily been in the critical care area. Hi, my name is Cecilia. I've been a nurse for 35 years.
the last 25 in the cardiac intensive care unit. I'm very happy to be there. We're here to talk about standardizing hands-off communication between all healthcare professionals, which improves patient safety. The Joint Commission of the U.S. has evaluated medical errors for 12 years and has found 70% of these adverse events were the result of poor communication between a healthcare team. A standardized approach to communication handoff is the Joint Commission's national safety goal. We will describe our handoff tool that we use at Maine Medical Center. Janet's going to present a case study, and then we'll use the SBAR method, which is our tool to show a different way this can be done.
Well, that's a rather dramatic example of transition in care that may or may not surface getting in with regard to age. And understand, it was accompanied by his family members, several of them, who were very distraught and emotional. And because of a recent death of a family member, 10 days before, this man's mother had died from a heart attack. The nurse, responding immediately to the family's anxiety and urgency, called the physician and explained it to the doctor, and the doctor immediately gave the orders for aspirin, nitroglycerin, oxygen, and electrocardiogram. I see lots of people message here. I'm sure you can relate to all of this. So the nurse immediately followed those directives. Within a very short time, the patient became semi-conscious. The family was very upset. The patient was attached to a monitor, needed a fibrillation, and unfortunately expired. Had low blood pressure, received 62 over 40 initially, and then expired from arrest within a short time, an unsuccessful resuscitation. That's pretty dramatic. And we're really wondering, is there any way can we improve this situation? Can we change the outcome by using more effective and standardized approaches to communication? There's so many barriers. We're all human. We all make mistakes. The system that we're working is very complex. There are limitations to our learning and our training. Many continuity gaps. There are time constraints, and the volume of information that you're handling every day is tremendous. In addition to that, we know from experience that there's a great difference between MD and RN communication styles. We have a problem right from the get-go. Our styles are different, there's a hierarchy issue. We have past experience to deal with our level of empowerment, the tone of our voices, and the level of respect between the skill level, the impact on how we communicate with one another. But this is one that we selected because we're most familiar with.
So at Maine Medical, we had training in this method, the physicians, we had team training with physicians. Also, all of our interactions